Good morning, everyone. I know we have a busy agenda for today, so I'm going to make this one relatively quick, but there was a good case report study in epidemiology that was posted in Emerging Infectious Diseases the other day, and I thought that would be helpful to go over again. Hopefully this will not be new to anyone who's been listening to our morning meetings, but again, I think it reinforces a couple of things, including the increased risk associated with singing and loud vocalization, as well as poor ventilation. So this is again, posted in Emerging Infectious Diseases. It's a study out of Australia from this past July, so our summer, their winter, actually, where there was a cluster of cases involving a church in Sydney. Again, we'll remind everyone that Australia has done an incredibly amazing job at managing the COVID-19 pandemic, and their case numbers have been very low. Therefore, they're able to do very detailed and sophisticated investigations of clusters and demonstrate what's probably happening everywhere, but they just have the ability to discern what's going on. So this was an outbreak associated with a church. Again, the index case was an 18-year-old member of the choir who developed symptoms on July 16th, was not tested until July 18th. Unfortunately, he sung at 4 one-hour services on July 15th and 16th, and on July 17th. On the 16th, that was before he actually developed symptoms, but was probably when he was maximally infectious, and was thought to be infectious the day before, developed symptoms as well. So he sang in this choir, which sits in a, oops, sorry, what's happened? I think I mistakenly hit a button. Can you guys still see this?
Yes, it's not in slide mode yet. But
there we go. How's that?
There, okay. Yeah.
All right, so stayed in the choir loft, did not interact or mix with the other congregants in the church. He did mix with his fellow choir members. And then after the outbreak was recognized, the public health authorities were actually able to identify almost everyone who attended the services and tested almost all of them. They also used video monitoring from recordings from the services to actually pinpoint where people were sitting and any potential interaction he had. Here's the epidemic curve, and you can see cases were both from services on the 15th and 16th, and one secondary case from one of the two services on the 17th, and you can see those attack rates there. Maximal attack rate of almost 6% of attendees at the service on the 16th, again, when he was probably most infectious, but still pre-symptomatic. And when they mapped out where all of the secondary cases were sitting, you can see that they were clustered in the congregation below where the choir loft was, but in a wide distribution, the maximum distance of, you can see that cluster of 7, 8, 5, and 12, that was essentially 50 feet away from where this person was singing the entire service. So again, I think, and should note that the ventilation in this church was poor. The ventilation system was actually off. They did have doors open periodically, which was really the only ventilation in this conical ceilinged church. And so probably the only airflow, unfortunately, they didn't do smoke testing, which would have been nice to confirm, but it seems as if the main convection circulation in the church is this clockwise circulation of air from the choir loft around the church, and probably, you know, in that main entry door on the left and then out that main entry door on the right. And it makes a incredibly good plume model that you would generally look at for outdoor aerosol distribution. But again, I think highlights a couple of things. First of all, singing is incredibly high risk and creates high amounts of aerosol virus that can infect at long distances. It also highlights the fact that the 3-foot rule or the 6-foot rule are really silly. What is important are density of people, concentration of virus in volume of air, and air currents related to adequate ventilation and air exchange, or poor ventilation and air exchange. and then any risk in terms of increasing aerosolization like singing. I think it's interesting to note that neither the piano player or any of the choir members who were also present in much closer proximity to this person developed infection through testing, and they were able to test, I think, all of the choir members. And so shows you the importance of being upwind from a potentially high source versus downwind, as all of these congregants were. So again, I think this reinforces the 3C rules that we've talked about, really the relative insignificance of distance versus what is the volume of air, concentration of people, and likelihood of a high risk source. And this shouldn't tell us anything new, but we will still ignore the lessons from this and continue doing the things that we shouldn't. So thanks.